We'll move into the next lecture of this session. So it's pre-op preparation in catheterization procedures and coronary artery bypass graft surgery. So we have two eminent speakers today, Dr. Sampath Vitanamasam, consultant cardiologist, and Dr. Rajidati Silva, consultant cardiothoracic surgeon, to address our session. So I invite our speakers to come to the panel, and it's open for you. And Dr. Sampath Vitanamasam is starting the session, and I just wanted to remind you that this goes as a joint session, and each speaker will have 12 minutes of speaking time, and at the end of this both lectures, you will have time for your questions. Thank you.
Good morning, chairpersons, ladies and gentlemen. We are going to talk about pre-op preparation for catheterization procedures as well as procedural preparation for CABG or cardiac surgery, which is done by my colleague Dr. Rajidati Silva. So I will quickly concentrate on the important facts as the nurses or the other medical staff we should aware of and when we are preparing a patient for catheterization. So just to recap a couple of things, the procedures that we are doing in the procedures, especially diagnostic and the therapeutic. These are some diagnostic procedures: coronary angiogram, right and left heart catheterization, and FFR, otherwise fractional flow reserve assessment. IFR is not available to us at the moment. Intravascular ultrasound, IVUS is available, all of you are aware of it. OCT, optical coherence tomography, is still not available in Sri Lanka. And these are some of the therapeutic procedures that we are doing in our cath labs. Percutaneous coronary interventions, percutaneous transvenous mitral commissurotomy, in short term, all of you are aware, PTMC. Valvuloplasties, ASD, VSD, PDA, or PF4 device closures, coil embolizations, and septal ablations, transcatheter aortic valve implantation. Couple of cases that we have done. Mitral clip is still not available. Atrial appendage closure is pending. So those are the procedures that we are doing in our cath labs at the moment. And the most importantly, I want you to know how we prepare a patient for a catheterization procedure. And I know some of you may feel it's simple. The patient, you are asking patient to come to the hospital or the wherever the pre-procedural place, and you take to the cath lab, and after that you are discharging. But I think our preparation at the moment in most of the hospital is not in the optimum level. From the consent to the after care. So a couple of things that I wanted to highlight, and I will highlight the places that we usually go wrong. Written informed consent, one of the most important things that all of we should care of, including the nurses, doctors, and all of us, not only the doctors. And then I will categorize this into small boxes for you to keep it in mind easily. So the first is the consent. Second, that the things mainly you should concentrate on the history. What's the procedure? Why the patient came to the hospital? And really is indicated. Even though you are not a doctor, it's your role, I think, to take care of these things just to minimize errors at least, or minimize unnecessary delays. Whether the patient had previous procedures and investigation, whether those things available to the patient. Say, for example, simply, if the patient has undergone CABG in the past, and this time the patient coming for graft angiogram, and it's, I think, your responsibility to keep the previous notes ready, keep previous angiogram reports ready for the operator. So it's easy rather than finding those things out while the patient is in the cath lab or in the theater table. And whether the patient is allergic or asthmatic, history of renal disease, regular drugs, whether the patient is on insulin, steroid, or other nephrotoxic drugs, history of bleeding diseases or intracranial bleeding. So those things, I think even though you are not a doctor, you can easily get from the patient. And the blood pressure measurement, access site, usually the access site is prepared initially by the nurses with the help of sometimes the other staff, so better to have some idea. And most importantly, that we are neglecting patients' psychological status. Most of these patients are very anxious and sometimes is tremulous before the procedure. So if you identify these patients prior to the procedure, prior to they are put into the catheterization laboratory, you can do quite a lot for those patients. And essential investigation findings, full blood count, renal profile, fasting blood sugar, chest x-ray, ECG, echo, and those investigation. And sometimes the nurses or even the doctor says, this patient's reports are not available. But if you are taking a couple of minutes, you can sometimes find the reports within last 2-3 months, which is very well acceptable. So then whether patient needs to be fasted or whether the patient is fasting. So this is again important thing, because we now experience sometimes you are keeping the patient on fasting from the previous day 6 p.m. and he is still fasting the following day 12 midnight. So that's how we are doing procedure, because we don't have a proper plan and nobody asks about when the procedure is, nobody plan about it, and the patients are unnecessarily fasting and then getting into unnecessary complications and also complaints from the patient. And then the pre-medication, loading doses, which is really necessary, or what's the loading dose that has to be given, what's the correct time, and the antibiotics, whether it's needed to be given or not necessary, and anxiolytics for anxiety, whether it's need to be given, all those are important. I think the nurses and the other medical staff can play a big role in these aspects. And the documentation is again very important thing, because how difficult for us to find what's the time of the loading dose, what drug has been given, what hasn't been given, who has given. This information is very difficult to gather in our routine writing style. So it's better for us to, even from the nurses, and not only the nurses, the doctors, everybody, your writing should be legible. And then the time and date, what time, what date that you have given it, and the essential facts, why you have given, what drugs you have given, and who has given in authority. All these are very important for us to find when we are considering these things. And I told you, the most important fact is informed consent, but we are neglecting this side. I just want to quickly go through the principles, the 4 main principles of informed consent that we need to get from all the patients who are coming to the cath lab procedure. The patient must have the capacity, should not be a child, should not be a mentally incapable person. The medical provider must disclose information on the treatment, test procedure, including the expected benefit and risk. So basically, the patient should know what's the procedure and what's the complication, what the outcome. And the patient must understand what you are telling to the patient, and the patient must be voluntary grant without any influence from your side. So most of us experience, we are not taking practically, as for doctors and the nurses and anybody, the proper consent. සමහර වෙලාවට අපි දකිනවා සිංහලවත් දෙමළවත් බැරි patient කෙනෙකුට ඉංග්‍රීසියෙන් consent එක අරගෙන තියනවා angiogram එකට පේලි දෙකයි patient කොහෙන් හරි අස්සම් කරලා තියනවා. That's the consent. So totally unacceptable and illegal. So we have to concentrate on those things. Consent form, there are a couple of things that when you are taking a consent, couple of things, legally these things are important for you to write in the BHT. And ultimately, at the end, both you and the doctor has to be, doctor and the patient has to sign at the bottom. So when you are taking a consent, at least you should know the risk of the procedure. And as you know, most of the patients, sometimes they can't reach to the doctor and reach to the nurse and ask, Miss, make a bayayida, make a karot mokak veida. And those are the concerns that our patients have. And most of the patient doesn't have even a very basic idea what they are coming for. So you should know the risk of the procedure and also the percentage of risk, just to tell what proportion that this can happen. And most commonly done investigation is angiogram risk. Risk involved in angiogram, a small risk of serious complications, usually basically a safe procedure, serious complications less than 2%, heart attacks, strokes, injuries to the blood vessels, and arrhythmias, allergic reactions, nephropathies, bleeding, serious bleeding, infection, and very rarely death. The chance is 1 in 5,000 cases. And when you take into the PCI, the risk of these things almost double. Say, for example, dying from a PCI, the chance is 1 in 2,000 to 3,000. So the access site, I will just quickly pass this slide. And the important things that I need to touch, the pre-medication with antiplatelet drugs. Usually nurses are involved in this, and there are theoretical benefits and also theoretically harm of considering antiplatelets. As you know, this is a blood thinning drug. There can be excess bleeding, and sometimes if you give dual antiplatelet, aspirin, clopidogrel or aspirin, ticagrelor, there may be an unnecessary delay for bypass surgery or any other surgery. So there may be complications also, as well as you have to consider the good side of these things. But current teaching, this is 2020 ESC guidelines, what they say, even for acute coronary syndrome, if patient is ready for angiogram within next 24 hours, and if you are not aware of the coronary anatomy, only give aspirin. Don't give clopidogrel or ticagrelor, which is to give once the coronary anatomy is known. But if you get the patient with acute coronary syndrome, and if you don't know the time of the procedure, angiogram, and it's going to be postponed, it may be fair enough to give dual loading with dual antiplatelet at that point. These are the antiplatelet that we have, and pre-medication, you have to assess the patient, and also thereafter, the most important thing is reassurance. That is more than enough, and if you sometimes you may need tablets. At that point, shall I suggest invite Dr. Rajitha De Silva to come and present, so then I can speak the balance thereafter. So till he ready, pre-medication for allergy with hydrocortisone or methylprednisolone in an emergency case, or otherwise you can give prednisolone. Rajitha, over to you.
Thank you, Sampath. I would like to invite you to come to the panel, and to Dr. Rajitha Silva, consultant cardiothoracic surgeon, to take over from here.
Thank you very much, Disna, and thank you very much, Dr. Sampath Titanwasam. So basically, my talk is about the preoperative assessment in cardiac surgery and how to optimize the patient for cardiac surgery. So what I'm going to do is, I'm going to talk about what are the types of cardiac surgeries we do, and what are the complications patient can get, and then to prevent that, how we are going to optimize the patient. So that's the whole idea of this talk. So first, let's see what are the types of surgeries we can do. The commonest surgery is coronary artery bypass graft surgery. Then you get the valvular surgeries, that is mitral and aortic valve surgery. Then you get the aortic surgery, which is aortic aneurysms and aortic dissections and so on. Then you got the heart transplantation and end-stage heart failure treatment. And then again you get the congenital heart surgery also. So now after doing all these kind of surgeries, now the techniques and the management of the heart surgery is so developed, usually the patient will be recover very well. And they will recover usually within 5 to 6 days, and they can go home and like this without any problem, and they will go back to the normal work within about few weeks after keyhole surgery, or maybe within 1 month they can go back to the normal routine work after open heart surgery. But having said that, there are a set of complications can happen. So what are those? It's after the cardiac surgery. Now the success rate is about 99%, but still there's about 1% chance any patient can end up in having a mortality or neurological complication, something like a stroke and minor cerebrovascular accident, and sometimes people can have a pleural effusion, respiratory complication like pneumonia, and that kind of thing. And also there are patients who can have a very bad chest wound infection, something which I have shown you in this slide, a bad infection. So these things can happen. But then the question comes, how we are going to prevent it. Now I'm going to take you through, when I'm talking about the preoperative assessment, I won't tell you this story. Now this is a car, this is a vehicle, and you see the engine of the vehicle, so which is the driving force of the vehicle. And if you compare that with the humans, so you got the heart, and heart is the engine force of the human being, and in addition to that there are so many organs like kidneys, lungs, liver, all those things, a brain, everything there which supports the patient. In the vehicle also it's same. You got the engine, but in addition to that there are so many particles. So whatever you do with the engine, if you prepare the engine and it works, but if the chassis and the tires and all those things are not having a problem, then there's no point of having the car with the running engine. It's like the heart. So if you do a good job at heart, but if kidneys are failing, liver is failing, patient get a stroke, then there's no point of having a repaired heart. So that's why it's important to have a very good pre-op assessment to find out all those things. The key to that is have a very good pre-op workup. So how are you going to do that? It's starting from the basics. So history, taking a very good history and good examination, physical examination. Then we are going through the routine investigation, and there are some specific investigation as well. And we can actually think about it like with the example I told you earlier, like engine and comparing the engine to the heart of the human being and the other organs. So basically our workup will depend on two things. One thing is pre-op workup, assessing the heart itself. How good is the heart, whether there's any problem, for example, what is the ejection fraction of the heart, whether it's low, whether it's normal, or whether there's any valvular heart disease which might need intervention during the bypass operation, or when the patient is going for a bypass valve operation, whether there's any coronary artery disease which will need the coronary intervention. And also then that is the workup of the heart. At the same time you will have to do the investigation and find out about the other systems also. So that's what you give with the other investigation. So we'll go to that one by one. So these are about the cardiac function and the other organs. So history and examination I told you. So we'll go to one by one. So in the history, you must always assess the present illness, obviously the symptoms, what kind of shortness of breath patient has got, what kind of angina he has got. You can go into the Canadian the scale, and also the past history of previous cardiac surgery and current medication. That's very important, and the allergies. For example, current medication is very important. If the patient obviously is on antiplatelet drugs, we should stop it about few days before the surgery. And previous cardiac surgery is something very important. The patient should not come to the operate in theater without surgeon knowing whether the patient has got a previous cardiac surgery, because the first time cardiac surgery and the redo cardiac surgery is a completely two different scenarios. So it's always important to look into all those things. And the social history is also important in the management of the patient. Occupation, hand dominance especially, because we are taking the radial artery in most of the patient. So if the left hand is dominant, so we should try to take it from the right hand. And then the review of the systems, you must check the eyes and the dental hygiene, false teeth, because those things are important, especially in the valvular surgeries, because those can lead to infective endocarditis. And cardiovascular system and the respiratory system, you must check in the peripheral vascular disease, abdominal aortic aneurysm, and bronchial asthma, COPD, and the genitourinary system, gastrointestinal system, where the patient has got a history of gastric ulcers, gastritis, and GI bleeding. That is important because the patient, most of the cardiac patient who is going through the pump surgeries, on pump surgeries we give heparin. We keep the ACT about 400 to 500. So that means there's a higher chance of bleeding if the patient is having a pre-existing gastric ulcers or the gastritis. Then again, CNS and the muscular system. Always must check whether there's any stroke or TIA or mental status and ambulatory patients, all those important. Especially the stroke and TIA history is very important, because in routine investigation we do carotid duplex if the patient is more than 60 to 65 years old. But there may be patients who has got a TIA, a young patient, so then we won't be doing that kind of things if we haven't taken the history of with regard to the TIA and stroke. Because we don't want patient who is walking to us with the chest pain and problem with the heart, and going back, heart is fixed but his brain is having a problem. He's not working, no paralyzed patient. And hematology is another important thing when it comes to review of systems. The bleeding disorders we'll have to look into, because another complication can happen after cardiac surgery is the postoperative bleeding, which can cause tamponade and can give danger to the life. And obviously the diabetes, hypothyroidism, those things also has to look into. The physical examination again is the same thing almost. You must look into the basic physical examination, and those are the normal routine thing. And especially carotid bruise you must look into. That's special attention to that. Then the peripheral pulses are important, and the Allen test is done to check the radial artery. And the venous system examination, that is actually venous system examination of the lower limbs, because the long saphenous vein is one of the commonest conduit we use in the coronary artery bypass graft surgery. Then the blood and investigation, serological, there are routine investigation like full blood count, ESR, liver function test, renal function test. So those are routine. And also fasting blood sugar and lipid profile, PTINR, those things are the routine things we do. Then urine analysis. Then it's obviously we are going to assess the heart with the ECG. We look at the heart rate, rhythm, and the conduction anomalies. If there's a rhythm abnormalities and the conduction anomalies, now we are lucky to get there are electrophysiologists available most of the places, so we get their opinion, and then we look into the current and residual ischemic changes also. Then chest X-ray, it's important because you can find out so many things, whether there's any cardiomegaly, pericardial effusion, and also whether there's any calcification in the aorta. That is something important, because if there's a calcification, that means we might have problems when we are doing the cannulation and when we are going on bypass machine, and the patient might end up in a stroke. So these patients will end up in doing a CT aortogram to find out the more detail about the calcification. So this is the echocardiogram. So that's also very important, but basic test. You basically look at what is the ejection fraction, whether there's any valve anomalies, whether there's any hyperkinetic segment, and then systolic or diastolic dysfunction. And transvagal echocardiogram, very important in the assessment of the valvular heart disease, especially the mitral valve disease, because it's very important to the mitral valve repair rather than replacing the mitral valve. So assessment of possibility of doing the mitral valve repair can be done mainly by the transesophageal echocardiogram. So usually it has to be done with the surgeon and the cardiologist together, have a good discussion to see what is the possibility of doing the mitral valve repair. These are some photos how to do the echocardiogram. Then the coronary angiogram, obviously after coronary angiogram only patient will come to us, and so it will tell us the severity of the coronary artery obstruction, dominance of the coronary arteries, and the coronary artery aneurysm and ectasias, and that kind of details. And there are some other specific tests we'll have to do before the cardiac surgery. Those are MRSA screening, nasal swabs and throat swabs and groin swabs. And we always do the HIV and hepatitis serology and exercise testing and functional significance of the coronary artery stenosis if it is needed, if it is indicated. And pulmonary function testing to find out pre-existing lung disease, and especially when you are doing the keyhole surgery, mid-cap and multivessel disease, we need to stop one side of the lung. And so therefore we need to find about the pulmonary function test especially. And the CT aortogram to find out calcified plaques and aneurysm if it is indicated only. Carotid duplex scan we always do after about 60 years old, or whether if there's a history of TIA and stroke, to find out what's the obstruction of the carotid artery. And also the lower limb venous duplex scan to find out the suitability of the long saphenous vein for bypass operation. This is how you do the pulmonary function test. Okay, this is the CT aortogram. Yeah. Thank you.
Now it is open for questions. First one from our online audience. It is to Dr. Sampath Vithanwasa. They are asking about, now we get a lot of young ladies in reproductive age group for cardiac catheterization procedures. What about doing urine HCGs? Is it urine HCGs? Because young females in reproductive age group coming for cardiac catheterization procedures.
Definitely, I think the first thing is in the history, menstrual history, when to see. But there are most of the occasion, you can exclude the pregnancy by just taking the history.
Yes.
But definitely, yes, of course, if there are prolonged, this last regular menstrual period is more than at least 6 weeks, and if it's having regular cycles, probably that's a good thought to think about it.
Yes, of course.
Yeah.
And can I ask you a question? You said about that taking precautions when there's history of allergy. But do you recommend giving IV hydrocortisone and chlorpheniramine routinely for all patients before procedure, or is it not necessary?
I don't think that any drug unnecessarily should be administered to any patient without a proper indication in unjustifiable way. So if there is any allergic history or a prone condition like asthma, eczema, or some sort of that type of history, you can take elective precautions, that is usually prednisolone. In a case of, like, say for example, some patients may have got history of anaphylaxis, extreme cases, could be fatal. There we have a lot of immunologists. We can get their opinion also for better safety. But otherwise, I don't think that routine administration of prednisolone or even the antihistamine for all the patients can be recommended.
Yes. Anything?
Okay, my question goes to Dr. Rajitha. Rajitha, what is the recommended time period that you have to continue dual antiplatelet therapy following bypass surgery?
That's usually depend on whether it's off-pump surgery or on-pump surgery. After on-pump surgery, it's about 1 year. 1 year. And but after off-pump surgery, it's about, I would say, you can continue, it's more than that, about 1.5 years to 2 years. Because after off-pump surgery, there's always a chance of getting platelet aggregation. So that is the reason.
Okay, thank you. And at the same time, I just wanted to find out now, in patient with severe calcific rheumatic valve who are obviously going for valve replacement, is there place for TOE assessment still?
Well, it's like this. This now, it's always better to have a TOE assessment. I think it should be a routine. We do the TOE when you are doing for a valve operation. But you are asking about the perioperative one or the preoperative one?
Preoperatively. Do we have to perform the TOE preoperatively as a routine?
Yeah, but if we know it's a calcified mitral or aortic stenosis or aortic valve disease, then if we know that, then the chances of repairing that is very low. But having said that, there are few people, only less than fingers of your hand, few surgeons who try to operate on even the calcified valves, not in this in countries like Vietnam, Thailand. There are people who are trying to that, but most of the time, if it is calcified mitral or aortic, that's mean straight away for replacement. So in that case, I don't think it's really necessary. But perioperatively, it may be a good practice to have a TOE during the surgery, especially post-operatively when you are coming off bypass, because then you can see the paravalvular leaks. That's the idea. If you see a paravalvular leaks, then you can go back and do something, rather than when you are discharging the patient in day 5, you say we find out, okay, then there's a paravalvular leak. It's better to know that when you are just coming off the bypass.
Thank you very much. Thank you.
That comes to the end of this session. Thank you so much, Dr. Rajitha and Dr. Sampath, for participating and giving your valuable time, spending your valuable time with us.
Thank you very much.
Thanks.